Okay, we're recording now. Welcome to a Good Hormone Health webinar. Tonight's talk is entitled, Is Sleep Apnea and Snoring the Cause of Your Weight Gain and Fatigue? And our guest speaker is Dr. Jay Khorsandi from Snore Experts, who will be talking about a fascinating link between sleep apnea and snoring and weight gain and fatigue. And I wanted to introduce my patients and also the patients around the country to the issue of sleep apnea and how important it is for weight gain and fatigue. Most of the people that come to see an endocrinologist have some issues related to weight gain and fatigue, and even after I find hormonal problems, which I often do, they still have sleep problems that could be due to apnea. So I think it's very important for people to learn about sleep apnea, determine whether you could have and get the treatment you need to go hand in hand with my treatment hormonally. So without further ado, we'll turn it over to Dr. Khorsandi, Dr. J as he's called, and go ahead.
All right. Thank you, everyone, for joining us, and thank you, Dr. Friedman, for inviting me on here to speak about this topic. Hope everyone had a nice first weekend of summer. We had a great time here in LA this weekend, and off we go. So a little bit about me. I'm going to just make this a little bigger here. Okay. I went to UCLA for undergrad. I got my bachelor's of science there. I attended Northwestern University in Chicago, where I got my dental degree, and spent some time when I came back in LA at UCLA Dental School teaching residents about advanced dentistry. Been doing this for a little over 17 years now, and it's been quite the journey. One of my earlier endeavors was, after being an associate for a couple years, I created and developed a big practice in downtown LA. Was there for about 10 years, and was a lot of fun. Was very fulfilling. And then I had an opportunity, though, to do something different, and actually sold my practice, moved to New York, Long Island area, and went in a different direction to become partners with a couple different guys to open up a chain of dental offices, what's known in the industry as a dental service organization. They're up to 17 locations at this point. So that's still getting bigger and stronger. However, New York life wasn't for me, no offense to anybody in the East Coast. So ended up coming back to where I grew up in the LA area. And when I did, I made a transition transitioned into dental sleep medicine. And that's something that kind of really kind of fit with what I was looking for, and kind of a bigger picture type thing, rather than doing simple fillings and root canals and things like that. I'm a member of the American Dental Association, California Dental Association, LA Dental Association, the AADSM, which is the American Academy of Dental Sleep Medicine. It's the dental division of the American Academy of Sleep Medicine and the California Sleep Society. So when I returned here, I ended up co-founding and partnering to create this place called Snore Experts, which is where I'm currently at. We are the leader for snoring and sleep apnea in the LA or Southern California area. We've got 5 locations, and we're out to change the face of snoring and sleep apnea in this area for now. We're going to talk about what's an oral appliance, but I actually created one. It's called the Epwa K being from my last name, Khorsandi, and I'll show you that later on. We're going to talk about CPAPs as well, and as a dentist, you don't usually correlate the two, but because of the unique situation of what we do, I have learned and given out many CPAPs, probably more than any dentist in the country, and we're going to talk about that as well. And NightLase, that's a new unique thing, and it's a lot of fun. It's a laser snoring therapy, and another one of the options for treatments. So off we go. I want to just keep things kind of simple. I call it the 3 N's. Hopefully this will be rather informal, where it's not too heavy duty. I want it to be a little informative. You can pick up some nuggets, and inspiring, you know, whether you take action to get yourself treated, or if there's doctors here, whether they want to take action to further learn more and treat patients. So we'll have some fun here. So the spectrum of sleep disordered breathing, you know, what is this all about? We'll go down the list here. Number one being primary snoring. This is the one that we're all familiar with, that is kind of the laughing stock, and it's usually what brings people in to see me. This is the snoring, classic snoring without obstructive apnea with potential frequent arousals. It's what we hear at night. It's what drives our spouses crazy. Upper airway resistance syndrome, UARS, is kind of the progression of the snoring. It's a little bit more heavy duty. It's labored breathing, disrupted sleep, yet you're not stopping breathing yet. It's heavy duty snoring is what I call it. Hypopneas, these are actual partial reductions in airflow. You're not stopping completely, but you're in between heavy snoring and stopping completely. And obstructive sleep apnea, number 4, we're going to spend a bit of time on that one. That's the classic stopping breathing at night. It's recurrent, partial, or complete upper airway obstruction. This is when we get blockages in the airway. And there's actually no absence of airflow despite respiratory effort. So we're trying to breathe at night, but we're not getting any action or any breathing. So why do we snore? I guess that's the first question, right? Basically, as we fall asleep, our bodies relax, our muscles relax, we lose tone, everything kind of settles down. Gravity will have more influence, and the tissues will start to draw together, including the tongue being the biggest one. As air passes across these tissues, they'll start to vibrate. And as they do, that's the start of snoring. On the other end of things, what is obstructive sleep apnea? So this is the final stage, and this is where it's a complete blockage of the airway for at least 10 seconds. No air comes in or out. It can happen from 5 to 100 times per hour, and we're going to talk about that. That's called the AHI. And that's a very significant thing there. And lastly, you can lose up to 50% of blood oxygen during the night, which is the second biggest component of this apnea. I actually had a patient this week, and we're going to talk about him. He actually lost 55% of his blood oxygen, and he was 29 years old. What makes snoring and sleep apnea worse? Well, the two biggest things I always tell patients is age and weight. So as we get older, we're going to lose muscle tone. This is going to happen more often. And as we get older, we tend to put on more weight. And the heavier we get, the more fat accumulates around the neck, the more reduction in airway you have, the more chances of collapse and blockage. Those are the two big ones. The rest are more on a short term, I guess. Body position being something you can change night to night. Supine is sleeping on your back. This will generally make symptoms worse. Sleeping on your side will make it better. Sleeping on your belly can help. Some patients, it doesn't matter what side they sleep on. If they're hanging upside down, they're still going to have snoring sleep apnea. Alcohol consumption. Alcohol is a depressant. It'll increase snoring and apnea if consumed before bedtime. This one's another big one we get all the time, especially when spouses come with patients, and they'll say, well, it's bad all the time, but when he has a few drinks, it's off the charts. And we also see that when we do sleep studies, patients will come back and say, you know, I had a couple glasses of wine that night, and we'll look at the numbers, and more often than not, they're way worse. Certain medications, relaxants, opioids, these things depress the system and cause more problems. Anatomy is another one as well. I'll have patients in here that are athletes, very lean, marathon runners, all kinds of different swimmers. I've had them all. And they're not your typical presentation. They're not big guys, football player size. I had a woman last week, she was 5 feet, 100 pounds, and her husband's like, I can't sleep in the same room with her. And in these cases, it may be a genetic component where I'll ask the patient, do you remember your mom or your dad snoring a lot when you were younger? And they'll say, yeah, you know, off the charts. Well, then they were kind of dealt a bad hand as far as anatomy goes. Orthodontics and extractions. About 3 out of 4 patients we see here have had orthodontics in the past when they were younger, where the orthodontist took out the teeth called the premolars. They're kind of in the middle of your arch. Typically, they've had crowding. They'll take those teeth out. The problem is they shrunk those teeth, the front teeth back to close those spaces. And what that did is actually shrunk the size of the mouth, pushed the tongue further back down the throat. And when you fast forward that back into their 30s, 40s, 50s, these symptoms start to pop up or get worse and worse. What are the symptoms of sleep apnea? So what brings people in here? Loud snoring with observed or non-observed gasping for air. This is the biggest one, obviously. Getting up multiple times to use the bathroom during sleep. A lot of patients will come in here and they'll say, well, you know, I snore a lot, or I wake up with a dry mouth, or I'm tired. And then I'll ask them, are you getting up at night multiple bathroom trips? And they'll be like, yeah, actually I am. So that's a big one, and we'll talk a little bit more about that too. Memory problems, brain fog. Patients will come in and say, I used to recall things better. Lately, it's harder and harder to remember things or recall things. Difficulty concentrating goes hand in hand. Excessive daytime sleepiness. We're going to talk about this again as part of this webinar. Weight gain, obesity, see that all the time. The problem with weight gain and obesity is we just mentioned that as weight goes up, apnea goes up. And the problem is as apnea goes up, weight will tend to go up as well. So it becomes this vicious cycle. Morning headaches, we see that quite frequently. Lack of dreaming, we're going to talk about that. GERD, another common symptom. And hormone imbalances, which is Dr. Friedman. I'll have him chime in as well and dig in a little bit deeper into that as well. So how to tell if you're being affected by poor sleep. One of the screeners we use in this practice is called the Epwa sleepiness scale. Basically, it's like a little survey. You see there the questions, I think about 7 or 8 of them. The number 0 to 3, 0 meaning never, 3 meaning highly frequent. And basically what happens is if you take that, add those numbers up, and fall into those categories, that's a sign of you affected by sleep apnea potentially, and you're extra tired. I mean, typically we see patients here from 11 to 20 on the numbers. If you're interested in doing this for yourself, you could either take a picture of this with your phone or just Google Epworth sleepiness scale. There's PDFs, so you can print one out, try it, and see where you're at on the scale. Okay, medical consequences of sleep apnea. So what's going to happen if you either have this or have had it for a while? The 2 biggest ones I see here, high blood pressure or drug-resistant hypertension, very, very common, and type 2 diabetes. Patients are coming in here on metformin all the time and blood pressure medications. Teeth grinding, that's something obviously a little bit closer, near and dear to my heart. I used to make night guards for patients all the time, and I would say, hey, you should wear this at night. You're grinding your teeth. You're probably stressed from work. Now that I'm in this world of sleep disordered breathing, I've learned a little bit more, and I'll recommend these mouthpieces that we make. And I'll tell patients, this isn't because you're having daytime stress. This is because you're having nighttime stress, and you're basically choking at night. And what that's causing is you to tense up and actually clench and grind your teeth. So very common. Weight gain, we talked about that. Reflux, we talked about. ED, not as often talked about with us here or in general, but I would argue that it's way more common than people want to talk about. Again, that can go back to a cardiovascular correlation. Mood disorders, depression, very common here. In this industry, people are coming in, patients are coming in, either they're upset or depressed or angry, or the spouse is. And a lot of it has to do with losing sleep. I'd be angry too if I wasn't sleeping at night, or whether it's because of myself or my spouse who is keeping me awake. So that one's a common one. I see patients on antidepressants all the time. Likelihood of a heart attack is increased by 3 times, 4 times likelihood of a stroke. These are statistics that are out there. When you have snoring or sleep apnea, you're putting a lot more stress on the body than it needs. It's going to accelerate majority of disease processes. And there's only 3 things that are really going to kill us at the end of the day. One of them being heart attack, stroke, the other being cancer, and the last one is neurodegenerative disorders. So all of these can be linked to poor sleep. Metabolic syndrome, again, Dr. Friedman can talk a little bit more about that. And premature death, again, going back to accelerating the disease process, and also going back to falling asleep behind the wheel and crashing. That's going to be premature death as well. So some additional consequences, secondhand snoring, again, that's a biggie, and people may, we'll have couples come in where the husband will say, and I'll ask the patients, Is it bad enough where your spouse is leaving the room? Some will be like, yes, every night. I haven't slept in the same bed with my wife in years. Other ones will be the very tolerant spouse will say, no, 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 we don't do that, but it's affecting them. Sleepiness slows down the thought processes. Again, back to kind of daytime fatigue, inability to remember things, brain fog, slowed reaction time. See that one. I've had patients actually fall asleep behind the wheel of a car and crash. Fortunately, I haven't had any fatalities, but I've had some people hit objects and cars and poles. Very scary situation. Job performance. So a big one here, especially in cities that are metro dependent. I believe there was a couple incidents on the East Coast where train conductors fell asleep, caused major accidents, casualties. Think about this. If you're sitting on a plane and you're flying across country, what if your pilot had poor sleep the night before and is now drowsy while he's flying your plane? Or your surgeon, these are real impacts that can affect people. Okay, so snoring, sleep apnea, hormones, and weight gain. So sleep deprivation, whether from bad habits, work, devices at night, iPhones, iPads, lifestyle, partying, drinking, or sleep disorder breathing, which is apnea, these will negatively impact metabolism. We're going to talk about things called leptin and ghrelin, which are two big ones. Leptin, I don't know if you, Dr. Friedman, if you want to chime in on these things here, if you want me to go through it. And
just go ahead. I'll add something. I think, I went over these slides, so input too. So.
Yeah, so these are the big ones here with weight gain. Leptin being the hormone that makes you feel full or inhibits hunger. These levels will actually decrease with poor quality sleep. So a lot of patients will end up wanting to eat more. Ghrelin, again, making you hungry, this is also increased with poor sleep. So patients will wake up saying, hey, they're more hungry in the morning. They end up wanting more kind of carb-type foods, poor choices in diet. When you say more ghrelin, less leptin equals a weight gain. So patients, obviously, when they start to see that correlation, they go, yeah, I'm always craving, carbs and sugary foods and chips and different things like that. And we'll see that actually diets change when they start to sleep better, that they'll start to change their habits and their diets, which is a lot of fun. Cortisol is the stress hormone. Levels of this are elevated in people with poor sleep. Again, they'll crave more sugar and fatty foods. It's just like, comfort foods. If you've been in academics or if you're a student, when you had tests and a lot of load on you or stress from work, we're going to reach for that pint of ice cream or that bag of chips. Except in this situation, you're not really stressed from outside environmental things. It's actually your sleep that's causing you to crave these types of things. Insulin resistance.
Yeah, so I'll add things on this.
Go for it.
One is, I think people need a good quality sleep. Quality. So I tell my people you need 7 hours of sleep. I mean 7 good hours of sleep. Somebody's waking up every 15 minutes and they're only sleeping half the time in those 7 hours. They're not in good sleep at all, and that leads to the diabetes and obesity. It leads to the high cortisol. Cortisol at night, for some reason, is the main problem. Cortisol day should be high. It's good when it's high. Cortisol at night, that's really dangerous for people. Leads to the obesity, leads to that comfort food. So I think this idea about good sleep and good quality sleep is so important to have good hormones.
Yeah, absolutely. I agree 100%. Couldn't have said it any better. Yeah. As far as insulin resistance, again, that's another big one there too. There's been some studies that show that with minimal REM sleep, this will disrupt insulin regulation, decreased resistance, and elevated blood sugar levels. And I'm sure Dr. Friedman can go deeper into the consequences of that. But I see that all the time. All right. We're going to talk about, oops, I think I skipped one. Okay, fatigue. So the other end of things. So one is obviously weight gain. The other is tiredness or fatigue or EDS, excessive daytime sleepiness. Why does that happen? Well, what happens is, just like Dr. Friedman mentioned, if we're getting, I have patients in here that will sleep 9, 10 hours, and they'll be like, they say that they didn't even feel like they slept at all. So to me, it is all about quality. You want to get a good, solid, I've had patients come back who have poor sleep, and they'll say, now these nights I put my head on the pillow, next thing I know, my alarm clock's going off. That is ideal, and I love that. But the patients who aren't being treated or who still have some ways to go, they're suffering because they're getting what are called arousals and fragmented sleep. And that kind of goes back to the fundamentals of sleep, where we sleep through stages, and we go through stage 1, 2, 3, REM sleep. This is when our body's recharging. I tell patients it's kind of like plugging in your cell phone at night with wires that are kind of shoddy and breaking apart. We've all had that wire that's breaking down, and we're trying to charge it, and it's just kind of bing, 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 making on and off noises. That's kind of like poor sleep, where you're not getting that full charge, and then your performance is going to suffer the next day. Hypoxia, desaturations. This is when our oxygen levels go down. Think about it this way. When you're falling asleep and you end up holding your breath, there's a thing on a sleep study which we'll talk about. It's called a pulse oximeter. This is measuring your oxygen levels, and the longer you hold your breath, the longer that number is going to go down. I have one in the office, and I put it on patients' fingers, and I'll say, hold your breath, see how low you can get it. They'll rarely break the 90 percentile number. Yet in these sleep studies that they're doing, they're getting down into the 60s, 70s, 50%. Half of your blood oxygen is being gone, and that's going to make a big impact. Again, that's back to poor oxygen perfusion. You're looking at the two biggest things, which are your brain and your heart needing oxygen, and they're going to get impacted the first and the strongest. Big thing with lower testosterone levels in men with apnea. There's research on that. I get a lot of patients these days. It's weird, from mid-30s to mid-50s, where their testosterone levels are decreased, their energy levels are decreased, and they're suffering from poor sleep. So all these things go hand in hand. Vitamin D levels, I know I talked to Dr. Friedman about this earlier. There are research that shows, vitamin D being reduced in people with apnea, and I think there's a lot of room for people who can supplement with that and get better sleep and better levels. It's a powerful hormone and antioxidant and anti-inflammatory.
Yeah, so I like 25 hydroxy vitamin D levels to be between 30 and 50.
Yep.
So you can have your doctor check those and try to adjust it. It's not clear that your sleep's going to get better if you supplement, but I think you might as well be at optimal levels.
Absolutely, I agree. You should, if you've never taken vitamin D or suspect there's things going on, talk to your doctor about getting a test on that and see where you're at, and then make some changes as needed. Yeah, absolutely. All right, so the good news. Good news is all these changes are reversible with treatment. We sit here and I talk to patients, and I'll tell them, okay, your sleep is this poor or this bad or one of the worst I've ever seen, or it's mild, and I'll tell them there's good news and bad news. Bad news is, yes, there's a problem. Good news is there's ways to deal with this, and if you give the body the right tools and means, it will heal. How do we find out if we have snoring or sleep apnea? So kind of the traditional method is what's called, well, the way we find out is with what's called a sleep study. The traditional method is what's called polysomnography, or PSG. Some patients may have already had this, or people on this webinar may have already had it. It's a very in-depth study and analysis. It's done in a facility or hospital. There's a lot of wires that are hooked up to you. I tell patients you look kind of like you're going to get a lie detector test. You spend the night there, and someone monitors your sleep. It's funny because we'll have patients that have had this test done maybe a decade ago, and they'll be like, I remember that one night. So it has an impact on patients. The other option is what's called home sleep study.
Yeah, so I think just it's clear, it isn't really real world. I mean, you're not sleeping in a hospital bed all the days of your life.
Yes, exactly. Yeah, the real world element on this is a little bit detached. Patients will say, I didn't sleep great that night anyways. You're not in your own bed. There's temperature issues. There's lack of preferences. There's usually someone else next door snoring through the roof as well, people walking down the hall. So it's a difficult test, and I've spent nights at these places as well too. So the alternative, technology, and I'll tell patients, I go, old school way of this is spend the night in a facility. Fortunately, technology gets better. Now there's a portable version. You can take it home. It's called an HST, or home sleep study. This is becoming more of the standard for obstructive sleep apnea diagnosis. It's a take-home test. It's very small. It's portable. You can see it on the picture there. It's like a headband. You're going to be in your own bed. There's not anyone going to be watching you, which is more of an issue for female patients, I've noticed. This is just as accurate as a diagnosis as an attended study. An attended study will measure other things like restless leg and different things which we're not testing for, but for the purpose of obstructive apnea, it works just as well. And the report is what we use for insurances as well. So very in-depth analysis. We can give it to the patient the same day. No need to go through different appointments and scheduling and get pushed back further and further. Very comfortable. One of the biggest advantages of this is the multiple nights. So we can do up to 3 nights with this study. What that translates into is that if you have a good night or a bad night, if you take Ambien all the time and you want to try a night without, which we've had this week, if you drink all the time and want to try one without, or if you don't drink occasionally, and sometimes you do, these patients will do experiments, or even just the fact of wearing it on your head the first night might be a little weird. Well, you still have 2 more nights to figure out the most comfortable way to wear it. So that gives us a bigger set of data, which is very nice. Yeah. So let's say you do the test. Either way, you get it done and you get a diagnosis of sleep apnea. What are your treatment options? What are you going to do next? We're going to talk about 4 of them here, and we'll go through these. Okay, the gold standard for snoring and sleep apnea is what's called PAP therapy, positive airway pressure, CPAP, APAP, BiPAP. There's a ton of them out there. We're going to talk about the 2 biggest ones here. And I'll start with CPAP on the right here. CPAP means continuous positive airway pressure. I tell patients it's kind of like a hairdryer. You flip a switch, it's going to blow air all night. The way CPAPs work is they're forcing air down the throat and they're keeping the airway open with air pressure. It's analogous to if I had a hose or a pipe or a straw and I continued to blow air through it and tried to squeeze the walls, it would be harder to squeeze. CPAPs require an in-lab titration study. That means that either you're going to do it on the first night you spent the night at the lab in what's called a split study, where half of the night you just sleep and the other half they put this machine on you, or they're going to do one night on what's called a diagnostic test, and then you're going to come back a second night as if the first night wasn't inconvenient enough. You're going to come back a second night, and then they're going to let you fall asleep, and then they're going to put the mask on you, and a technician is going to sit there and adjust the settings until they find the best setting pressure level that's going to keep you from having the apnea. Problem again with this machine is that as patients' needs, environments, different things change over time, a new lab titration study is often required. So the APAP, what is that? That's the auto-adjusting positive airway pressure. It's the machine that we use here and recommend to patients. The difference between the APAP and the CPAP is the APAP has a computer chip in it, basically, that's going to monitor how you sleep and how you breathe. What that means is that it's going to automatically change the pressures on the fly, every minute, almost every breath. And what that translates into is obviously you don't need to go spend the night for a titration study. The smart technology will automatically adjust, and that usually means that the pressures are going to be at the lowest amount you need throughout the night. Because what happens is oftentimes is the CPAP is set at a pressure that's when you're on your back and you're having REM sleep. When you're having REM sleep, your body's in paralysis and your apnea scores are going to be higher. Well, we're only in REM sleep for about 20 to 25% of the night. So the rest of the 70 to 75% of the night, that pressure is going to be too high. Or if you roll to your side, you're going to need less pressure typically, and that pressure is going to be too high. So the machine the APAP is way more advanced in that it can adjust for all those different things. If a patient has changes over time, the APAP can adapt. A lot of patients will come and say, I got a CPAP a couple years ago. The first couple months it was great. Then over time, I don't know, it just wasn't as great. Maybe they lost weight, which usually can happen with CPAP usage, or maybe they've had some nasal obstruction, or maybe they've started drinking. Whatever it is, those won't be accounted for in that machine. So the APAP is a nice alternative, and we recommend that. We also sync it to our computer, monitor changes night by night for patients. I can actually send signals to the machine and change settings from over the air. And patients will download an app on their phone and they'll track their progress and monitor what's going on day to day. These new ones have smartphone app connections and Bluetooth and Wi-Fi. So they're great. Surgical options. A lot of patients will come in here looking for the quick and easy solution. I would say maybe surgery might be quick, but it's definitely not easy. A very common procedure that in the past was common, about 10 years ago coming out of Japan, was called UPPP, which is uvulo-palatopharyngoplasty. This was a procedure that went in the mouth and basically cut out a bunch of structures, including the tonsils, the uvula, parts of the tongue. Very invasive, very painful recovery, not so great results. These days they don't do it that often anymore. However, because of the scope of the patients I see here, I see a lot of patients that had it done, and when I look in their mouth, they'll be like, and they'll say, I wish I didn't do it, didn't work that great. I think maybe 1 in 10 got a decent result out of that. Another surgical option is what's called MMA, which is not mixed martial arts. It's a maxillomandibular advancement. It's where surgeons, oral surgeons, will go and actually break the jaw on the top, the maxilla, and the lower mandible, and actually advance the whole lower portion of your face. Can be effective. This actually has research that shows that it is effective. However, it's very painful, can be very costly, a lot of side effect repercussions, and it's going to change the way your face looks. So you're going to look different. In some patients, it actually does help because the ones who don't have a chin will actually benefit more. But if you have a regular profile, you're going to look different. So we try and stay away from that as an initial therapy option. Oral appliances, mouthpieces. The bulk of what we do here are these. These are things that are placed in the mouth, and they move the jaw slightly down and forward. I tell patients it's kind of like a night guard or retainer or a double night guard. Basically, there's a top and bottom piece. You can kind of see them on the right there. And they're all essentially in the same function. They all move the lower jaw forward. The reason being the jaw and the tongue are connected. Jaw goes forward, tongue goes forward. Tongue goes forward, then the back part of the tongue, which is over here. I don't know if there's people on the video, but that's going to move forward and that's going to open up space. It's all about space management. Increasing the space for the tongue and the anterior part of the mouth and moving the tongue away from the back of the throat. This has been as effective as CPAP in mild to moderate apnea. We see it all the time here. Patients that have had mild apnea and been given a CPAP on a high pressure setting, and I've slept with CPAP machines. High pressure settings are very difficult to sleep with, and these patients were very low apnea scores. And we'll make them a mouthpiece and we'll retest them, and they'll get great results, better than they were with the machine. The results can be noticeable on the first night. We typically take a couple appointments to what's called titrate or adjust the appliance. We're dealing with millimeter movements here, so it's about finding the right position, the right distance to open things up without obviously overdoing it. So it takes a little bit of time with that. NightLase. This is something that we've added about 1.5 years ago to the practice. Still kind of a new procedure in the U.S. It's been done in Europe for over a decade. Basically, it's a laser snoring therapy. What it is non-invasive, non-surgical treatment to tighten the soft palate. Basically, what we're doing is over time, as we get older and as we snore or have apnea, the soft palate loses elasticity and gets more flappy. And we're using a laser to hit that area and cause the tissue to regenerate and make new collagen or neocollagenesis. What that does is it causes new fibers to produce and to get tighter. Think of like a sail, and when you crank up the straps, it stiffens up. I'm part of a Facebook group called Lightwalker, is the company that makes the laser. I put a post up here on the right here, I just copied it. But those are some of the cases I did recently. Got quite the response there on that Facebook forum. It's a private forum, but people have now come to me as a go-to for laser, NightLase treatment. It is made for snoring. We tell patients that up front it's not indicated for apnea. However, patients who refuse a CPAP or refuse a mouthpiece or don't have any teeth, they might be candidates for this. Or if they don't have apnea and they just snore, then they usually typically will get great results with this. And that is the conclusion of my presentation. I wanted to thank everyone for hanging out and watching this. This is my contact information. Here, my company called Snore Experts, our locations, our website, phone numbers, my email. If you have any questions, you can take a picture of this with your phone or write it down. Be more than happy to help you or work with you. And I believe if you're not in the LA area, and Like to Find More Sleep Certified is kind of a sister company of ours, and that is a training company for dentists as well as a locator for patients across the country. It's kind of like Invisalign, where you can go in there and type in your zip code and find someone who is familiar with snoring and sleep apnea, oral appliances, and the such, and find someone out there that can help you. And I think let's do some questions and answers if there's some Q&A.
Okay, so use your chat button. And again, thank you, Dr. J. It was a great talk.
Yeah.
Thanks for sharing your time tonight. You please, you can email us at goodhormonehealth.com. And you're blocking the your screen's blocking the screen.
Sorry. There we go.
Okay. This is my website, and I'll put the webinar on my website at the top of the first page in a couple of days. So anybody that watches this on their phone and wants to see the slides or wants to share this with their friends, it should be on the website shortly. I'll start with the first question, and then we'll open the audience. So you talked about obstructive sleep apnea. Can you talk about the difference between obstructive and central sleep apnea, and does any of this apply to central sleep apnea?
Sure. So central sleep apnea is the other category of apneas. It's where the brain is basically not telling the body or the diaphragm to breathe. Very, very rare incidences of that. We don't really get that in our practice that much. If that's something that is actually noticed with patients, we'll see that. I've seen maybe one patient that had that, and basically we'll get them over to a sleep physician, and they will go ahead and get them on a special kind of machine that will actually help them breathe. But that's a very rare, and it's more of a neurological condition rather than an obstruction.
Great. Okay, so people can use the chat function and go ahead and send us messages. So the first question is from Jose Fuentes, Jose and Rose. Can you talk about how to monitor cortisol levels throughout the day? So I did give a webinar, I think it was my last webinar, on salivary cortisol home monitoring. There is a company called iCalc, ICALQ, that has a home salivary monitor. I have the webinars on my website and also have an article on it on my website. And it works with iPhone 6s and 7s now. You buy the strips. The strips, I think, are about 50 strips for $650, and it can measure your salivary cortisol in real time on your phone. So far, my patients haven't found it super accurate, but I think it can give you an idea of what days you're having high cortisol, what days you're having lows, and when your cortisol is high and when your cortisol is low. However, Dr. Fuentes asked the question about monitoring cortisol levels throughout the day. I think it's more important to monitor cortisol levels at night, because at night is when the problem is. So you can use this iCalc, or you could do salivary cortisols at night to determine whether your cortisol at night is high, and that's your hormonal cause for your fatigue, and that could be corrected with the devices that Dr. J talked about. I think people, you should still get tested for the sleep apnea, get treated for the sleep apnea, and I think your cortisol will come down regardless.
Yeah, that's a good question. Just wanted to add something on that too. As far as if the patients or doctors want to kind of dig a little deeper into this, another quick test they can do is there's pulse oximeters on Amazon that are recording. And basically, I have a couple of them, and basically you'll wear it throughout the night, and it'll tell you your lowest desaturation throughout the night. And if it comes back in the 70s or low 80s or 60s, that's a good little indicator that maybe there's something more going on.
Dr. J, can you talk about the app for the snoring?
Yes. So there's an app that's out there. It's called Snore Lab like laboratory, L-A-B. It's in the Apple and Google Play Store. What we recommend that to patients who are coming here to just track their snoring. It doesn't really it's not a sleep study, but it'll track their snoring. And we use that as kind of a guide in our therapy and our treatment, because as you know, snoring is reduced, typically apnea is being reduced. Sometimes that doesn't happen, but generally that'll help guide us along with the feedback from the patient. But again, if you want to dig a little deeper into what you're doing, or if you live alone, a lot of patients will come in and say, I don't know if I'm snoring any less or getting any better. I'll say, well, download the app and record yourself. In the old days, we would give patients a tape recorder, and hit record, but now it's digital. You basically just download the app, you turn it on, you put it by your bedside. It'll record you throughout the night, and the next day it'll show you on a graph how you did, and it's a great little tool as well.
It's really nice. It's really sweet.
I wish I invented it.
Yeah. But they don't it's free also.
It's free, and I think you can upgrade if you want to record more nights.
Right. Okay, Jose again asked about the time for night monitoring. I think it would be, if you want to do a couple times a night, see what your cortisol is with this iCalc thing. I think that would be helpful. I don't think it would be that helpful, but I would say probably the best time would be, maybe 2 or 3 in the morning. But I think it would be more important to do one of these apps to see if you're snoring and, how much you snore and what times of the night you snore. I think people have a debate between the husband and wife. The husband says, I don't snore. The wife says, oh, yes, you do. So this will put to rest that issue.
Exactly.
Susan asks, can you have sleep apnea without snoring? My husband used to snore terribly. Now he takes Ambien and doesn't snore at all, but he doesn't seem rested.
Yes. Okay. So yes, you can. You can have sleep apnea without snoring, and you can have snoring without sleep apnea. So those patients are called the silent apneics, and they're basically ones where you don't see that outward symptom of noise or snoring, but absolutely they can have apnea. My dad being one of them, he used to be a horrible snorer when he was younger, and now he doesn't snore at all, but I've tested him, and he's still pretty bad. So if you suspect any of that, absolutely get the sleep study or the test, and you'll be probably pretty surprised about what's going on.
Right. And, I don't think Ambien is the be-all and end-all. Ambien really can help people fall asleep, but it usually makes them, as Susan's husband said, they don't sleep rested. They don't feel rested. And, the whole point of sleep is to get rested, not just to have the hours of sleep. You want to have good quality sleep. And I think Ambien decreases the time into the deeper stages of sleep. So it's just really sort of masking the symptom. But I think, if there's sleep apnea going on, Susan's husband should get tested for it. Yeah. Catherine Brown says, thank you, I just downloaded it. Liz says, could you see the chats, Dr. J?
I see some of them, yeah. Okay. I wake up in the morning and I've thrown off.
Why don't you read that one? Okay. Yeah, go ahead and read that one.
Okay, so Liz says, I wake up in the morning and I find I've thrown off my sleep apnea mask. It's the only mask I can tolerate. It's a Philips Respironics mask that's a strap-like thing that goes under the nose. Any suggestions on how I can prevent this? So I'm guessing it's the DreamWear mask. That's the mask that we give to patients. It's called the under the nose. And Liz, I think if it's the kind you're talking about, it has the little connection off the top of the head where the hose connects. That seems to be the most comfortable one out there. They only get worse than that. Some patients will switch them to what's called the nasal pillows, where it's those 2 little things that go in the nose. Another option could be what's called a chin strap, where it's like a little belt that you can wear that can kind of keep that on there a little bit more. I guess one of my questions would be, why are you taking it off? Is it the pressure that's too hot, too much? Is it, water in the hose? Is it something else? I mean, we want to know a little bit more about why it's coming off, and then we can figure out how to keep it on.
And I think I want to add a couple points here also. So in general, I think most of my patients that have considered sleep app don't like it. It's, it's the rest of your life having this air blowing into your mouth. Yep. So that's why I think it's interesting to see if you have mild, if you can get away with some of the other types of treatments. And then I think the second question is, or a question for Dr. J, is the difference between nasal and mouth CPAP.
Mm-hmm. Okay, so there's different ways. Basically, the way a CPAP works is there's a box, there's a hose, and there's a mask. And that's the interface. There's different ways to connect to the face. One being in the nose, one being on the nose, one being under the nose, and one being on the full face. The way we start patients is just under the nose. That seems to be the most comfortable, because the more you connect to the face, the more uncomfortable the sleep's going to get. And a lot of patients will say, well, I'm a mouth breather, and I wake up, with my mouth gaping open and bone dry in the morning. What happens is, when you actually introduce positive airway pressure through the nose with a humidifier, the pressure at night will actually, if you open your mouth at night, it's going to come gushing out, and there's a mechanism in the brain that will actually keep your mouth shut. So we'll try and avoid using a full face or over the mouth one, unless it's, there's a patient that just absolutely needs it. So you don't want to go on the mouth style if you can avoid it.
Okay. So Liz's response that it's too hot.
It's too hot. Well, then you got to get the AC down. I'm guessing it's too hot in the room. Is it that?
Probably too hot with the mask on.
If it is that mask, there's these little fabric, I call them socks. They're like little sleeves that you can wrap around the mask, and that'll keep that silicone material off your face, and that might give you a little layer of insulation. It might keep it a little bit cooler. Or try connecting the machine, the mask, to the machine directly and skip the humidifier, because the humidifier is also going to heat up that air. So maybe the air, that would give you a little bit cooler air.
Okay.
Can the app differentiate? Oh, there's another question here. Can the app differentiate between my snoring and my husband's? Not specifically. It's just, it's kind of a microphone on your phone. If you want to differentiate, I would say go to a different room and do a little bit of a controlled study there. Because I have patients coming in that will, on that app, and they'll have epic numbers, and then we'll go back and play those, and it's actually the fan or the air conditioning or the TV. So you do want to make sure that the sounds and the noises it's picking up are actual you and not something or someone else.
But, I think the distance from the phone matters. So presumably you're much closer to the phone than your spouse is.
Yep.
So I think it's mostly going to pick up yours.
Yeah, I mean, if you're wondering about that, just record a night and then play it back and see whose noise it is. You can actually touch the sections of the graph and hear the noises.
Really? Okay.
Yeah.
Okay, do you want to answer?
Hear the dog barking, anything, yeah.
John's question?
Let's see. I see one from Melissa here.
Have you had or can give your thoughts on PAP therapy contributing to central events?
So I don't have a lot of experience with central. For PAP therapy for central apnea, you're going to need what's called an ASV, and those are much more complex machines and complex therapies, and that would be through a board-certified sleep physician.
Okay, Vicky says, good information as always, Dr. K.
Thanks, Vicky.
Thank you, Vicky. Kelly's, I used to snore and have terrible sleep till I got on hormone replacements. I think that's true also, especially estrogen. Women that are going through menopause, they sleep horribly. I would imagine when they do, their sleep studies, they're really bad. You put them on estrogen and they sleep much better. And then that being on estrogen and the better sleep helps them with mood and weight loss and things like that. She goes on, a horrible broken night of sleep. I get about 3 hours a night, but sleep great during the day. Coughing and heartburn are keeping me awake. I have to sleep upright and often with my head forward. I sleep best during the day. Normally, because of these and other issues and not snoring, I was focusing on getting GI and allergy issues addressed. I forgot to talk about sleep problems because I sleep during the day, so I feel rested. So I need to go back to my PCP or see if things change. I think, again, it's worth doing a sleep study, seeing what your sleep is at night, and trying to improve it. I think, our society works on people sleeping at night and being up during the day, so I would probably try to work on that. What do you think, Dr. J? Yeah,
there's been a lot of studies that that's shown perimenopausal and postmenopausal women will get a shift in fat distribution more towards their upper body and leading to an increased incidence of sleep apnea. So we see that a lot. I think hormone therapy is a great option, as well as, like you said, get the sleep study and see where that is. Dr. Friedman and I both mentioned, the three pillars of health, or the three fundamentals. One is nutrition, one is movement, and one is sleep. And when those are out of sync, you're going to get inflammation. Inflammation long enough over time is going to become disease. So whether it's pain, physical pain, or brain fog, or disease, you got to get these three things in order. Sleep being as important as the other two, and you'll see changes for sure.
Okay, Melissa asked a great question. Is there any validity to sleep studies you can order online, or should you get it from a doctor?
You know, I haven't seen any sleep studies that you can order online. That's new to me. I think there are websites out there that will ship it to you directly. If it's the same unit as we're using, it will be just as valid. But I would say you want to get that coordinated with the doctor, because there's a lot of things, comorbidities that could be going on as well too. So.
Yeah, and I doubt they treat you online. I don't think they give you a mouth guard via the internet. I think it's worth getting.
These days, there's a lot you can do online, but I would say, yeah, you want to have some kind of guidance with your treatment.
Okay, do you want to answer?
Yeah, let's see, I see Frederick's here. What if you get stuffy from the CPAP, even when clean, different humidity? I did have stereotactic radiation for clean. So if you get stuffy from the CPAP, or if you're stuffy and then trying to use the CPAP, either of those cases, I would say I would run it by an ENT or ear, nose, throat doctor. We use one here all the time, and get evaluated for nasal obstruction. A lot of patients coming in here have deviated septums and large turbinates, chronic sinus issues. Me personally, I had what's called septoplasty about 4 months ago. I had a lot of the classic symptoms of apnea or snoring, having teeth taken out as a kid, what's called a vaulted arch, or the roof of my mouth goes high up towards my nose, which resulted in a really bent septum, chronic stuffiness and nose issues. So a lot of patients who are trying to use a machine, if their symptoms are mild, the machine will usually overcome it. If it's chronic or severe, I would run it by an ENT. They'll either recommend either a balloon sinuplasty type therapy, septoplasty, or maybe just sinus rinses. I tell patients these little NeilMed sinus rinse bottles, go out there and flush out your nose, or even the simplest would be breathe right strips. Getting those and trying those out, and if you notice a difference with those, then you know that there's room for improvement in your nose. And now they make nasal dilator cones as well, which are these tiny little things that go in your nose, and they prop your nose open as well too. So there's a lot of room to play around there.
Jose's question.
I see another one from Frederick here. I now don't even use a humidifier. It dries me out, but at least I can breathe. Okay, there we go. Liz, my husband snores even with the sleep apnea dental device, though not as badly as before. Do you think he's still being helped by the mouth guard? Well, that's one of the things we do here is once we give a patient a sleep apnea or an oral appliance, what we're going to do is we're going to monitor their symptoms, and we're going to monitor their quality changes. Ideally, patients will come back and say, this thing's working great, I'm wearing it through the night, spouse is happy, patient's feeling better, or they've noticed an improvement, enough of an improvement. At that point, what we'll do is what's called a post-sleep study, where we'll do a follow-up test, but with the mouthpiece in their mouth, and compare those to the numbers that they had before they started. And that's going to validate whether they're being helped enough by the mouthpiece or not. If they are, we're done. If they're not, we're going to retitrate, reevaluate, make adjustments to the mouthpiece, maybe order a different mouthpiece, maybe add on the laser treatment, which has been a great addition to what we can do here, or maybe we'll refer them to an ENT. Maybe there's issues with their nose breathing, and once they get that cleared up and open up, ideally, what I tell patients is the more you can breathe from your nose, the less you're going to breathe from your mouth. The less you breathe from your mouth, the less problems you're going to have in your airway. So hopefully that helps.
Mm-hmm. So Jose's question is about how the Inspire implant compares to an oral appliance.
Big difference, big difference. So Inspire, it spent a lot of money marketing. I don't know how many people are familiar with it, but basically it's an implanted device that's put in your chest, kind of like a pacemaker, exactly like a pacemaker. And what it's doing is there's different leads, one going down to your diaphragm to measure breathing, the other going under your tongue and the hypoglossal nerve. These things are called hypoglossal nerve stimulators. And what they're doing is they're monitoring you during sleep. And if they notice apnea or blockage, they're going to basically zap your tongue to cause it to contract to open up the airway. I personally think it's invasive. I don't think it's going to do much for snoring, because snoring is not a complete blockage. I've seen a few patients that have had the procedure done, and they didn't give me great reviews on it as well. One patient, in fact, had a scar on his neck and said he got it done a couple weeks ago, was waiting for it to heal. When they came back to activate the device, they realized that the lead came off of the nerve, and he had to go back for a second surgery. So I've sent one patient for something like that, and that's because he was wheelchair bound and just didn't have any ability to put a mouthpiece in. But I would not recommend that unless a very last resort.
Okay, Lisa asks, I have both central and obstructive sleep apnea and have a ResMed S10, I guess that's the type of sleep machine. I have horrible sleep since ceasing long-term fentanyl use. Is there a relationship between opiates and hormones? Yes, so I wrote one of the most prominent reviews in endocrine reviews on opiates and hormones. It does suppress your testosterone, sometimes your cortisol, often your growth hormone, and often your thyroid. But you know, once you stop it, you should get better. And what are the hormones that affect your sleep? Estrogen and cortisol are crucial ones. Another one is called orexin. That is a crucial one. But the ones that, you know, I usually measure would be the nighttime cortisol and estrogen to see about hot flashes. I think those are the crucial ones. There is a supplement that I often recommend to my patients called phosphatidylserine, or Serophos it's also called, that lowers cortisol at night. The dose is usually 300 milligrams. It's a pretty benign supplement. You can take that to lower your nighttime cortisol. You can see if that helps your sleep as well. Some people find it quite helpful. Others don't find it that helpful.
What are your thoughts on melatonin?
I like melatonin also. You know, melatonin is pretty natural, very little side effects. It sort of mimics what the body's supposed to make when you close your eyes and, you know, in a dark room. So melatonin would be my #1 sleep medicine that I would recommend.
Good. Yeah.
Do you agree?
I agree. Yeah, I get it. The problem is, what these days is I get these patients in that have, or everybody, we're all accused of this is playing with, you know, electronic devices at night and blue light and you know, sleep disruption. And the more you have that phone or iPad or TV in your face, the more you're delaying that melatonin response.
Right. Yeah. So
you got to put
electronics at night. Yeah.
No electronics. My room has become a cave. It's blacked out. You know, put the phones away, spend time with the kids, read stories. I have special LED blue blocking bulbs that I put in now that will only emit in the red light spectrum, which is help my sleep too.
Right. I think most iPhones also have some a night adjustment.
Yeah, the night mode. Yeah,
night mode, which is probably pretty helpful.
It's a good start. Yep.
Yeah. Lisa also asked the dose of melatonin. I like to start with 3 milligrams. There's some people that recommended the 1 milligram dose, a lower dose. Not necessarily higher is better, so I would start with 3, go down to 1 if 3 doesn't work, and then maybe go up to 6 if 3 and 1 don't work.
How about magnesium?
Yeah, I like magnesium also. I like especially magnesium glycinate, although magnesium oxide and magnesium, what's the other one? Can't remember. There's another one.
Citrate, I think?
Citrate, yeah. I think they're all good. They calm people down. They help with palpitations. They help with, some people get this adrenaline rush at night. They help with that. It's pretty benign. 450 milligrams of magnesium glycinate is a good choice.
Yep.
Thank you, Jay. Do food allergies play a cause in sleep apnea or making it worse?
I think, you know, there's a cause for that. Patients who I stay away from mucus forming type things. You know, dairy. If you're getting, you know, smoking, obviously it's not an allergy, but irritants to the airway and the throat are going to, or you know, in the nasal passages.
Yeah.
Those are all going to make your night worse. Yeah,
I mean, I don't know necessarily about food allergies, but allergies in general. If you get a stuffy nose from your allergies, you're going to use your nose less, your mouth more, and that's going to be worse, as Dr. J said.
Yeah, seasonal stuff for sure. Absolutely.
Okay, we're at 7 now. We can take 2 more questions if people have a little couple questions, and then we'll call it a night.
Yeah, I think I saw a couple of people. John is on. Dr. Bouzis is a great resource for he's a dentist that does a lot of work similar to what I do, and I think he's out in Wyoming, John, or so he's a great resource on there. And Vicky was on here as well too. She's my past coordinator.
Okay, great.
So, yeah, and she's out in Delaware.
Okay, nice, good.
Yeah.
Okay, great webinar. Thank you again. Anyone else?
Yeah, great questions. Yeah, lots of good stuff.
Okay, so I'll post this shortly, and we'll think about a next webinar in a couple months. Thanks everybody for joining. Thank you, Dr. J.
Okay, thank you so much, Dr. Friedman. It's been a pleasure. Everyone have a great night. Any questions, please feel free to reach out to either of us, and look forward to hearing from you.
Okay, bye.
Bye-bye, guys.